The floor will be yours. So I'm starting the recording. Good afternoon, everybody, and thank you very much for joining us in our health seminar, which is organized by the Center for Primary Health and Social Care. My name is Giulia Raso, and I will be chairing the session today. So I'd like to introduce our speaker, Dr. Dom Conroy, who is Senior Lecturer in Psychology and Course Leader for the MSc in Addiction and Mental Health at London Metropolitan University. He has worked in different approaches related to alcohol consumption and its guidelines, drinking styles, and behaviour change interventions to promote moderate drinking. More recently, his research has focused on COVID pandemic and analyzing behavioral adherence or compliance to mask wearing. Such a challenging, we may say, new behavior to which Western society have had to adapt, not without some resistance sometimes based on patterns of cultural divisions, amongst other factors. But in today's seminar, Dom will be presenting findings from his study, which is a psychological intervention that was designed to promote adherence to wearing face masks during the COVID pandemic with students from a London-based university. After his presentation, we'll have time for questions and answers. You're welcome to use the chat box as we go along, so we can get back to the question at the time for discussion. So Dom, it's great having you here today, and the floor is yours.
Okay, thank you very much, Yolanda, and I hope people can hear me okay. The internet connection in my... Okay, that's great. That's great. Thanks, Yolanda. I think the internet connection is pretty good in the room I'm in, but please do, let me know in the chat box if it's not so good. There might be something I can do, but there might not be much I can do. So thanks for bearing with me with the connection. And it's really nice to be invited here. And thank you very much, Yolanda, for inviting me to speak at the London Seminar Series. And it's great to be able to share a little bit about some recent research activities with colleagues and with anyone tuning into this. So I'm going to focus in this talk on talking about some recent research that I've completed and published about using behaviour change psychological interventions to promote face covering use, face mask use, if you like, where required during the COVID-19 pandemic. And I'm going to use this sort of as an opportunity to talk about different things, so to provide a little bit of context, because we've got the time partly. I'm not entirely sure how long this will take, but because we've got the time, it's good to give, you know, just a little bit of kind of background to some of these things in the way that wouldn't be possible in a sort of 15 to 20 minute conference talk. So it's great to be with you and to share a little bit about this, and it'll be, you know, great to hear your responses and reactions to anything about the different things that I talk about that are to do with this this piece of research that I'm going to be talking about. So I think maybe some microphones are on there. Don't know if we can do anything about that. So as an outline of the talk I'll be giving, I'm going to be talking a little bit about, you know, these different measures of COVID-19 protective preventive behaviours. I mean, there are a few we can think about here. I focused on face mask wearing, and this project really came together in, let me see, it's hard to remember now, August 2020. So when we were really sort of only just sort of getting into the language as researchers of COVID-19 protective or preventative behaviours, as they're referred to. But yeah, we can think of a number of different sort of candidate COVID-19 protective behaviours. I'll talk a little bit about the measures of those, really just to point to a few articles if people are interested, that have really all come up since I've completed this study. So it's more kind of curious sort of curiosity around the different ways we can measure these discrete COVID-19 protective behaviours. So I'll talk a little bit about that. I'll talk a bit about, I'm conscious that we're all coming from slightly different disciplinary backgrounds, different research backgrounds. I'll talk a little bit about behaviour change interventions in the context of promoting COVID-19 protective behaviours. I'm not, I don't, do research all the time on behaviour change interventions, but this was, has been one part of my research over the last sort of 10 years or so. So I'll talk a little bit about that just to contextualise the behaviour change intervention that I used in this particular study, and that's a mental imagery intervention, which sounds a fair bit more exotic than I'm afraid it is. But it's an interesting technique. It's an accessible technique. It's a cheap, not particularly time-intensive technique designed to strengthen motivations toward a target behaviour. So in this case, the target behaviour being wearing face coverings where required during the COVID-19 pandemic. So talk a little bit about these things called mental imagery techniques or mental imagery exercises or mental imagery interventions as one way in which we can think about promoting behaviour change, promoting the target behaviours. So I'll talk about the study. I'll talk a little bit about promoting open science by publishing intervention protocols. Now, this is something that's come up as part of completing this piece of work, really. It seemed useful to be thinking about developing and publishing a separate protocol piece of work while preparing the main study here. And this has been quite an education for me. There's some very interesting debates emerging in the literature about the importance of or the role of protocols within broader issues around promoting open science, transparency about researchers, about their a priori hypotheses and everything else that goes with research transparency. I'll talk a little bit about potential future research steps with the kind of research I'll be focusing on this afternoon. So there are different measures coming along every week, it seems, to think about gauging levels of adherence to measures that we could think of as or behaviours that we could think of as relevant to COVID-19 prevention or the limiting the spread of COVID-19. And I guess the core behaviours that we think about that would come along in most of the articles that I've been looking at anyway, and I'm aware that the literature is getting increasingly large and diffuse, so it's quite hard to work through now. It is a very different kind of literature review that you do in January 2022 compared to when I was doing this in July 2020, really. So there, I guess the core behaviours we're thinking about are social distancing, face covering, wear, hand washing, and now vaccination status. But we have a cluster of different variables we can think about there. Vaccination status, vaccination intentions, vaccination hesitancy seems to be the emerging big vaccination variable, so target variable to measure. And it'll be interesting to see how this literature emerges and changes as we sort of enter a different phase of the pandemic, I guess. But there are other behaviours that seem to come up. So gauging, variability in staying at home when ill, variability in face touching, respiratory hygiene, avoidance of social gatherings, similar to social distancing, staying away from sick people, again similar to social distancing. But we can see that we could get quite fractured here in terms of thinking about a real range of discrete yet overlapping COVID-19 preventive behaviours. And there are composite measures. So there's a composite measure that Goudry et al. Presented last year, and there are references at the end of this presentation if you want to consult anything that I'm referring to here. But you can see just from that list there an example of the target behaviours that are being thinking of. And these items go something along the lines of how likely are you to adhere to following recommended COVID-19 preventative behaviours, a list of very unlikely to adhere through very likely to adhere. So we can see there one example of an emergent composite measure of COVID preventative behaviours. And there are a number of different studies, just like mine, that are focused on one single COVID-19 preventative behaviour. So there are studies that look at gauging social distancing. So Cheng et al. Report a 5-item scale with an example item: I maintain a distance of about 6 feet between myself and other people in the public. So yeah, we have a sense here of this is not going to be an entirely exact science. It never is if we're using self-report instruments in any kind of research, I guess. But it's sort of interesting to see how researchers have approached developing the phrasing for these COVID-19 preventative behaviours. We see another example in Cheng et al.'s supplementary materials, which is looking at disinfecting behaviours. Recall your cleaning and disinfecting behaviours during the pandemic, and then a range of different items which people can respond to. So, as I sort of was mentioning a couple of slides ago, this idea of vaccine hesitancy feels like the core COVID-19 preventative behaviour that we might be seeing, a really sort of interesting set of studies starting to come out on in this particular phase of the pandemic. So, for example, we have Roberts et al. Reporting in a UK context relatively low vaccine hesitancy, and some sense that there is variability by gender and variability by minority ethnic group or ethnicity as well. We have news stories, reporting findings like these every day. I mean, we can feel sort of saturated with these COVID-19 news reports, and I think it's going to take a while until we have a sense of the bigger picture and a sense of the real sort of moderators of these variables like vaccine hesitancy. But it's interesting to see these initial studies. These are clearly large, substantial in terms of sample size studies that we can be thinking about. And there was some sense in this Salam 2021 article about national context with the lowest vaccine acceptance rates, the lowest rates in the Middle East, was Kuwait, and in Africa, in the Democratic Republic of Congo, 28% acceptance rates, and several European countries as well. So we have a sense here of a really an awful lot of variables in motion, and an awful lot of sort of cross-cutting factors that might be involved in the core COVID preventative behaviour of our times. Well, that's how it feels in terms of the phase we're into now, vaccine hesitancy. There have been different vaccine hesitancy measures proposed. We have Freeman et al.'s 2020 measure here. So would you take a COVID-19 vaccine, approved for use in the UK if offered? And we have the more kind of normative type measures here. If my family or friends were thinking of getting a COVID-19 vaccination, I would, and a range of response options there. So it's interesting to see these different instruments, and I mention them really as sort of context for the study that I'm going to be talking about in this talk. So thinking about using behaviour change interventions to promote COVID-19 protective behaviours. I mean, this is it's a slightly different context than I guess anyone would be used to working in if they previously worked with behaviour change techniques for different kinds of behaviours. I mean, I suppose we could think of COVID-19 protective behaviours as relatively stable behaviours. We're going to expect high levels of adherence, given that they are legally mandated and come with substantial penalties if you're found to be non-adherent to them. And there's a whole context of, I guess, societal norms and values that might also reinforce these behaviours. So they feel like, for all sorts of different reasons, quite difficult behaviours to be thinking about measuring. And I think we'll see more ambitious measures probably coming out this year in the literature. But thinking about interventions to promote COVID-19 protective behaviours, that's relatively few sort of published examples of these at the moment. And again, clearly a lot of work, these are all prospective studies, I guess, or the great majority of them will be. So it will take a while with the peer review process for these studies to be coming out, but really relatively few at the moment. So there was a vignette-based experimental work revealing no effect of an information providing intervention reported by Bo-Kemper et al. There's another study looking at just 89 participants at 2 separate time points, looking at an information and action planning interventions. This was just a pre-post analysis. It wasn't a full randomized controlled trial. So we have sort of, a very sort of small but emerging set of studies looking to use different kinds of techniques to promote COVID-19 preventive behaviour. And there's a range of preprints and protocols that are also there that I haven't summarised, but I've included there if anyone would like to have a dip into the kinds of peer-reviewed publications we can expect over the next 12 months, maybe. So let's turn now to mental imagery intervention. So this is where I came into thinking about some sort of study in the context of COVID-19 from a behaviour intervention angle. So I previously completed one mental image study, then a meta-analysis of mental imagery interventions, and I'll come and describe these in a moment. But I'm just showing these Tricia Greenhalgh tweets here, just to have a sense of thinking about this idea of wearing face coverings. I mean, clearly all of us here are aware of that there is going to be some important COVID-19 protective role of wearing face coverings, but we have some really sort of clear sense here of just how massive that protective role could be if we scale things up at a population level. So this sort of sets the scene in terms of thinking about having a behaviour change intervention in the context of COVID-19 protective behaviours, discrete ones like wearing face coverings, even though a lot of people are going to be doing it anyway. A lot of people are going to be doing it because it's mandated, or these other reasons. Thinking about an intervention that might just pull the numbers of adherence up a little bit further feels of interest. So mental imagery interventions have been around for about 25 years now, and they come from Shelley Taylor's work in North America in the late 90s, where she was thinking about mental imagery interventions in the context of promoting educational motivation. So they've really only kind of spilled over into the health psychology, into the behavioral science domain in the last sort of 15 to 20 years, I guess. They come in all shapes and forms, mental imagery interventions. And the idea is it's thinking about people, asking people to rehearse and think about what would be involved, what would be a positive outcome involved in enacting a particular behavior. And another kind of mental imagery intervention is thinking about the kinds of strategies, kind of processes that would be involved in success in undertaking a target behavior. And these are referred to separately as outcome imagery interventions and process imagery interventions in some sections of the mental imagery literature. But they're referred to in a really diffuse number of different ways. You hear about visualization studies, you hear about mental simulation studies, you hear about mental imagery studies. Sometimes mental imagery means something that people are actually looking at, some sort of images. Sometimes there are sonics involved, but the kind of intervention that I'm interested in, that I use in my research and that formed the core set of studies in this meta-analysis from 4 years ago, they involve people thinking about a target behavior, positive outcomes, strategies, involved in enacting a behaviour, or both, or a control group. Thinking about them, visualizing them. So here's where the mental imagery bit comes in as part of the intervention. It's encouraging people to have very strong images of, how it's going to work, them, drinking moderately or taking regular physical exercise, and then writing about it in some way. So it's some sort of, it's an image in terms of prompting people to think about visuals involved in enacting a particular behavior, but then cementing that by asking people to write about it elaboratively. So this is what the intervention is. It's not sort of showing imagery or anything like that, in the sense that I've used mental imagery interventions myself in research, but this is what we mean by a mental imagery intervention in the sense that I'm using it here, and in the sense that I've used it in research. So this meta-analysis sort of brought together really quite a small selection of studies. It's not a hugely used behavior change technique, although it does appear in the various taxonomies of behavior change that you find with different research groups in the UK and beyond. But there were 26 imagery studies, sort of straddling a number of different behaviours. Most of them are about taking regular physical activity and promoting moderate alcohol consumption, with 33 independent data sets across those 26 studies. And our meta-analysis sort of demonstrated, non-trivial, small, average corrected effect sizes on post-intervention behaviour. So most of these were proper randomised control trials rather than pre-post behaviour test studies. So we had, a corrected D value here of 0.23. So it's, sort of a reasonable type of effect on subsequent behaviour, and also on behavioural intention. So if we're thinking about promoting changes in behaviour, then we would also be interested in thinking about the most sort of proximal driver of behaviour. How motivated people are, how much people intend to drink moderately, how much people intend to take regular physical activity as a sort of proxy outcome variable. And there was a slightly smaller corrected effect size for behavioural intention demonstrated from this meta-analysis. And there were some interesting moderation effects as well. So yeah, to give you an illustration of this, a non-drinking mental imagery exercise to reduce alcohol consumption among UK university students. Individuals were randomized to one of these 4 conditions, an outcome condition, so thinking about positive outcomes of not drinking during social occasions when socializing when other people might be drinking alcohol. A process condition, encouraging people to think about required strategies for not drinking alcohol when socializing when others might be drinking alcohol. A combined condition involving both the outcome and process condition, and a control set who did actually do something. They were completing a drinks diary for the same time period for a month. And there was some there was a vignette here, so this was slightly sort of tricky studies to put together, in the sense that you have to give people a sense of what we're talking about. We're talking about thinking about potential positive outcomes. So there's something going on there. So thinking about, for example, in the context of this non-drinking study, potential positive outcomes, giving examples of sort of saving money, increased willpower, but it was quite a range of different responses that people came up with in their elaborated sort of free text responses to this, which ranged from the more concrete, like saving money, to the more abstract, I guess. And the same with possible strategies. And just to move to the findings here, so we had a fair size sample, 211 students, primarily female, across a large number of university departments. We had some effect of each of the outcome imagery condition on subsequent weekly alcohol consumption, and there seemed to be an effect relative to the control condition of heavy episodic drinking incidence of heavy episodic drinking or binge drinking, if you like, being reduced subsequently amongst participants who took the process condition relative to the control condition. There was no effect of the combined condition, and people were doing quite a lot of that intervention. So that may explain that. How do we explain what's going on here in terms of mechanisms of action? Well, I would start by saying imagery is a simple, low-cost way of changing behaviour, of prompting reflection in a more elaborative way, but it's fairly low burden for participants. Strengthening links between thought and goal-directed action is something that Shelley Taylor and her research colleagues have suggested when finding successful effects of their mental imagery interventions in the context of educational motivation among students. The bioinformational model here might suggest that imagery strengthens different kinds of relationships between mental imagery, emotional memory, and physiological responses. Other authors have been interested in thinking about a neural basis for mental imagery effects. So there are a range of different ways in which we can think about the effects of imagery, but it's something about strengthening motivation to conduct a target behavior. So I'm going to turn now. I'm conscious of time here. It's always hard to know how long I'm going to talk for, or someone's going to talk for. But yeah, thinking about this mental imagery intervention, and hopefully you've got a sense of what I'm talking about with mental imagery interventions. These are slightly strange ideas. But thinking about using mental imagery intervention to promote face covering adherence, and this is published in Psychology and Health last month. And there were particular aims and objectives here, so I was interested in putting together a collaboration with people who are interested in mental imagery interventions, and to think about whether or not we could use these in the context of the COVID-19 pandemic for a target COVID-19 preventive behaviour. So we're interested in looking at the efficacy of a mental imagery intervention to promote increased and sustained wearing of face coverings, in terms of how it was measured, in terms of how frequently someone wore face coverings within a defined period. You'll see the actual measure in a couple of slides' time, but also to look at, as you've got a sense of from the previous slides, to think about potential behavioural correlates and mechanisms of action by using theory of planned behaviour constructs. So things like intentions to wear face coverings, attitudes towards face coverings, subjective norms about face coverings. What the people who are important to us think about. What our perceptions of the people around who are important to us, their beliefs about wearing face coverings, how that may have some sort of bearing on our plans or our actual wearing of face coverings. Perceived behavioural control over wearing face coverings, things like barrier self-efficacy towards wearing face coverings. We'll have a sense of these items more clearly in a moment. And a mental imagery specific variable, which is used in different mental imagery studies, imagery ability, this idea that people dispositionally vary on their capabilities to use mental imagery about a particular target behavior. So also to explore potential demographic and personality trait moderators of intervention effects. So there were some specific hypotheses here. So relative to the control condition, we were hypothesizing that individuals randomized to these different imagery interventions at time 1 would subsequently report, so 1 month later, greater wearing of face coverings, and that effects of mental imagery would be mediated through perhaps enhanced attitudes towards face coverings, enhanced subjective norms, perceived control, or self-efficacy towards wearing face coverings. So we were interested in this idea of how would the intervention be working? What was the mechanism of action? Maybe it's one of these social cognitive type variables that could account for any potential effects of the mental imagery. And there were a set of moderators as well we're interested in. We'll go through this in detail, but I mean, these are the kind of measures I use in a lot of the intervention studies that I've conducted. So thinking about these theory of planned behaviour measures, and sort of talk through those a little bit in the previous couple of slides, but you can see here the sort of a diagrammatic relationship of the theory of planned behaviour. I'm just conscious here that we're all from different backgrounds, so people may use and think about theory of planned behaviour all the time. So you know, on the far right side here we have behaviour, and the theory of planned behaviour is conceptualizing, theorizing intention as the strongest, most proximal predictor of behaviour, and then these different variables, attitudes about a target behaviour, subjective norms about a target behaviour, perceived behavioural control about a target behaviour, will themselves be predictive of intention, and perceived control will also independently directly predict the target behaviour itself. So that's just some background to the sort of proxy measures that were also involved in this study, to give you a sense of how those were being used. These are incredibly texty slides. I do apologize, but these are more really to give you something if you're interested in the specific measures that we use as a follow-up resource. I think these slides will be available afterwards, but if you're interested in these measures, they're available here. I will just focus on the behavior measure because this is key to explaining the study. So the key target behavior for this study was self-reported frequency of face covering adherence in the previous week. So it's, you know, having a clearly defined time period and a specific measurable quantifiable variable, and that ranged from responses from 1, never, to 5, always. And this was based on a study by Fisher et al. 2020, which was one of the few studies at the time to report this kind of measure. There was also an intentions measure, and I'm just showing here for completeness the range of other theory of planned behavior type measures that were included in the survey. These were sort of drawn from related literature, recent mental imagery studies that field colleagues had used that felt useful and relevant to think about here. I'll just zoom in on the personality traits here because these are of interest. So sort of conscientiousness and narcissism felt of interest to measure in the context of variability in adherence to wearing face coverings regularly. And these emergent light triad traits, faith in humanity, Kantianism, and I've lost one of the other ones, and I've forgotten what it is. Honesty, I think the other one is. But yeah, it seems useful to think about these as potential moderators of intervention effects. So the data, as we finally reached to it, was difficult to work with. There were ceiling effects. A very large proportion of the participants had maximum scores indicating that they always wore face coverings where required. So it's not entirely surprising, this sort of finding, if you know, given the legally mandated nature of the behaviour, given the social context and the moral context around wearing face coverings. What we did here was recode the data dichotomously so that anything that was something other than absolute adherence to wearing face coverings was recoded with a 0, and people who always wore face coverings, those kind of responses were coded as a 1. So we had a binary variable. This is not ideal, but this was how we approached the data. We categorize this as suboptimal adherence, so responses on those on that ordinal scale of frequency of wearing face coverings was coded suboptimal adherence, and scores of 5, which was always adhering to wearing face coverings in the previous week, was labelled as full adherence. So we conducted a set of logistic regressions. I'm including here, this is tiny print, we can see here our participant characteristics and some details on the variables, some descriptive statistics. But you can see there the very high adherence at baseline, so 70% 73% full adherence to wearing face coverings at time 1, 74.4% full adherence at time 2. There are a range of correlations that were interesting that came out of the study. So I've highlighted these in green. So 5 refers to behaviour times time 2. So that's follow-up behaviour at 1 month follow-up. So you can see here correlations with wearing face coverings. Time 2 follow-up was predicted by was correlated with higher intentions, attitudes that were more strongly endorsed wearing face coverings, stronger subjective norms, greater perceived behavioural control, and so on. And there were also was one correlate with narcissism. So there was some sense of how things could work at a multivariate level from these initial inferential statistics. Unfortunately, there was no effect of the intervention at all. So despite guiding you through lots of interesting stuff here about mental imagery, the mental imagery intervention did not work in this study. So this is visually represented here by a red box around the outcome, process, and interaction of the outcome and the process factors. So we had no effect of the imagery intervention. What we did have from this logistic regression was evidence that past behavior was a very strong predictor of subsequent behavior. So we had some sense here of how habit was relevant to thinking about what was most predictive of subsequent wearing of face coverings, and also gender. Gender was a predictor. So being male meant you were more likely at time to have suboptimal adherence to wearing face coverings, and that matches the findings of other studies, and they're actually reported in the last couple of days by Robert West at UCL in an article in The Guardian. So this is all quite disappointing, but we were quite interested as well, and we were thinking about how we could understand this and explain this. What we did next was run a subset analysis looking at just the suboptimal adherence participants, and there were 81 of these. It was a sample of just 297 individuals, but we had this sort of fair subset to work with. We found here that stronger subjective norms were predictive of subsequent adherence to face covering. So more strongly endorsing the idea that other people who are important to you in your life, such as friends and family, having the perception that they believe that face covering is important is going to is predictive of being more likely to adhere to wearing face coverings yourself. And also intention, and we would expect links between intention and subsequent behavior, but intention, so motivation, planfulness to wear face coverings subsequently, was itself an independent predictor when everything else was controlled for of subsequent face covering use at 1 month follow-up. Another thing we reported in this study, and this is reflected in the title of the article here, was thinking about a power analysis. So we looked at our very small effect sizes for this study that had come out from this ineffective, non-efficacious behavior change intervention. And we were interested in thinking what sort of sample size we would need, and our conclusion was you would need a sample of many thousands of participants to see some sort of effect, whatever that effect might be, of a behavior change intervention used in the context of COVID-19 behaviors. So there may be other studies that have come out in the last week or so, but I'm not aware of other behavior change technique type studies that have been used in the context of COVID-19 protective behaviors. But what's going to be really interesting, I mean, these studies will start coming out, And it'll be really interesting to start sort of pooling that evidence together when it comes to the point where it's possible to do systematic review and meta-analysis of this data. So just briefly, and I'm conscious of time here a little bit, but something that came along as part of doing the study was publishing a protocol of this piece of work. And just sort of focusing here, and this is an educational experience for me, but thinking about pre-registering trials, and there are all sorts of stakeholders that we can think about who it's important to if we're thinking about an open science climate. But thinking about, I think, if we're thinking about this from a purely research perspective, I mean, I've put a number of different registry purposes here and stakeholders that would stand to benefit. But from a research perspective, thinking about reducing publication bias, so not sort of squeezing out those p-hacking and all these other sort of practices that we can think about here, but showing up front that we've got a set of hypotheses in our published study protocol, and then seeing whether or not we have data that attests to that when we have actually sort of completed and published our research. So this was an interesting experience for me, and there's a mental imagery intervention protocol study. It's a very different kind of experience putting together this as a research article, but I'm really sort of sharing this information because I'm not sure if people are sort of widely aware of this. This is something that I sort of got to learn about through doing this piece of research. So I had read a mental imagery intervention protocol in BMC Open, which publishes different kinds of articles, but among these are randomized controlled trial protocol articles. I published in this peer-reviewed title called Trials, and there's a link to the protocol there if you're interested in it. But it's quite an interesting way of circulating your research, ideally earlier. This protocol has only recently just come out, in fact, at a very similar time to the full study. But it's a good thing to think about if you're preparing all of those materials for a randomized controlled trial for any kind of research you're doing. You'll all be doing different kinds of research. But if you're thinking about doing that and you've got a protocol already registered that's reported in your main study article, it couldn't hurt to think about a separate standalone article that's presenting the protocol. And there's scope there to have your online supplementary materials available to researchers in the field. So I really just wanted to mention that as something that I became aware of through doing this study. Okay, so just to check what else I'm going to talk about here, and this is me sort of more or less coming to the end of things here. But I mean, it's hard to know where things go from here. I mean, we have a changing climate. I mean, I've talked about behavior change interventions used in the context of, I guess, health psychology or health promotion type research. Behavior change interventions applied to COVID-19 preventative behaviors. I mean, we're going to see a lot of these coming out. I would imagine in the next year or so in different shapes and forms. I mean, it's hard to know where to go in terms of a future research agenda, if only for the fact that we don't know what the core COVID-19 protective behaviours are going to be. I mean, there will be chops and changes from a UK context alone over the next 6 months. So it's hard to know what the core target behaviours will be. But I think it's going to be a very interesting sort of area of research to watch. I mean, one thing that I'm interested in is thinking about contrasting different behaviour change techniques. So thinking, for example, about looking at a mental imagery intervention versus an implementation intentions type of intervention, so a more commonly used behavior change technique. But I mean, as you can see from the study that I've reported, you would need really a very large potential study sample detecting effect sizes. But of course, if it was looking at a range of different COVID-19 protective behaviours or behaviours other than wearing adherence to wearing face coverings, perhaps behaviours where you might expect a higher degree of variability, that might make such a study more feasible. But and as I say that in the second bullet point, gauging multiple COVID proactive behaviours in tandem. So face covering adherence, social distancing, hand washing, vaccine hesitancy. And it's going to be interesting to see what kind of measures start to come out that can kind of tap into that variability with a little more sensitivity, I guess. Thinking about a range of moderators in terms of behavioural adherence here. I mean, again, there are sort of different bridges to cross before we get to think about all the different moderators we could look at for an intervention study used in the context of COVID-19 protective behaviours. But I mean, candidate mental health moderators, anxiety, depression, resilience. We could think of all sorts of factors that might be sort of correlated with variability in specific COVID-19 preventive behaviours. Something to do with gender identity might also be interesting to look at. I mean, this finding that that men are less likely to wear face coverings than women, which has been found in other studies as well. Looking at particular, endorsement of traditional masculine type norms, traditional masculine values is only one example, but that might be something quite interesting to think about in the context of adherence to COVID-19 behaviours. And of course, thinking about interventions in specific sample contexts, so thinking about specifically targeting interventions at individuals from minority ethnic backgrounds, particularly where we know that uptake of COVID-19 behaviours or where vaccine hesitancy, there is some evidence that it's higher in particular minority ethnic groups. So these are just my very, very tentative ideas about potential extensions and expansions of behaviour change techniques used in the context of COVID-19. And thank you very much for listening to me for the last 50 minutes and all of my own hesitancies in presenting this. But it's been great sharing this research with you, and I'd be delighted to hear any feedback or questions you may have.
Thanks very much, Dom, for this great presentation. I suppose we are now opening the floor for questions, and I think we do have some already. Let me go through the chat. There is Digby. Is the image about desired state to achieve or the steps to get there? Digby, if you're here, I mean, if you would like to pose your questions, you're welcome. But
thank you very much, and thanks, Dom, for a very interesting presentation there. My first question, I think, was answered during the course of the presentation, where you spoke about the imagery as involving both what you call the outcome condition, which is what I meant by the desired state to achieve, and what you refer to as the process condition or conditions, which would be the steps to getting there. So that's been answered already, but I wonder if I could pick up on my other question, which is to what extent are subjective norms or perceived behavior control influenced more broadly by individuals' socioeconomic or cultural contexts and backgrounds?
Yeah, okay. Thank you, Digby, and they're both really interesting questions. And I think the mental image interventions there's some very curious terminology involved with in these, and I'm glad that the outcome and process condition question was addressed earlier. I mean, so thinking about links between measures of subjective norms and perceived behavioral control, and some sort of probably quite coarsely defined demographic variable of white people compared with non-white people. That's not something that we have looked at in the study. We might have the numbers to do it, but I agree that that would be a very interesting question to think about variability, particularly in subjective norms. I'm thinking here about perceived behavioral control on the spot, and wondering about that. I mean, we could think about all sorts of different causal pathways, I guess, but yeah, particularly between subjective norms and socioeconomic and cultural context backgrounds would be very interesting. Was there a particular starting point for thinking about links between those two theory of planned behavior constructs and those kind of factors that you were that you were thinking of, Digby?
I suppose partly from what your data that you've mentioned, either your research or earlier research, showing, for example, around vaccine hesitancy and how that is prominent in, I think you mentioned the Bangladeshi community. So I was wondering to what extent that might be a wider socioeconomic or cultural influence that's coming through there, which is impacting on individual norms and their own perceived behavioral control.
Yeah, yeah, and I think, you know, it's such small numbers in this particular study, and with no intervention effect, sort of looking at moderators of these effects. And this was a big lure of this study in the first place. I mean, I was conducting this research at University of East London, and I had colleagues working on this in universities with a relatively high proportion of individuals students and staff from minority ethnic backgrounds. So it would have been possible in theory to look at, you know, some, you know, these sorts of discrete ethnicity moderators, or so we would have been looking to look at socioeconomic state as a moderator. But yeah, we weren't ultimately in a position to look at these moderating factors, but I agree that this is very interesting, and it will be interesting to see what research comes out similar to this in the next 12 months or so, addressing those interactions.
Great, thank you very much. Thank you.
Dom, on that note of Digby's question on the social, economic, and cultural context and backgrounds, perhaps this another possibility could be to use, apart from the theory of planned behavior, but this is something that we did with social distancing behaviors, is to, and self-isolation as well, is to consider some measures around the socio-ecological model. I mean, we use both in order to a bit account for the social context, the socio-economic context, the organization, community, as variables as well that are influencing behavior. In particular, for example, in social distancing, I suppose in face covering could have also an impact, this notion of seeing people in your neighborhood, how they are behaving, and how that can, you know, when you go out on the street and you see, well, and this is something that I question, is there too many people wearing, you know, a face mask, and you can kind of have a sense of what your neighborhoods are doing or not. I mean, it can also, certainly the same applies to social distancing. Staying at home, you see a lot of people around, you say, well, are they following the rules or not following the rules? And that can also, it has been proven in any case from other studies, and it came out of also as a predictor in our studies. I mean, it has also an impact. Yeah, there's just a comment on that. I suppose that could be bringing both, yeah, the individual and the societal context.
Yeah, it's a really interesting point you raised there, and that is interesting to think about sort of socioeconomical variables in the context of this. I mean, one of the it's interesting, you know, to hear both your and Digby's responses are thinking about sort of more sort of contextual factors here. I mean, I think there is a tendency amongst these, you know, sort of social cognition type behavior change techniques to be very decontextualized, to be very focused on thinking about variables at an intra-individual level. And I mean, certainly when I was putting together this intervention study in the summer of 2020, I was, very much working within a sort of traditional behavior change model, and that is very decontextualized. But I entirely agree that there are all sorts of interesting research avenues thinking about different theoretical constructs and providing a more contextual, nuanced account of the kinds of behaviors that we're talking about.
Thank you. Yeah. So Mia, I think she's asking, there can be a lot of more, it's a comment, there can be a lot of stigma surrounding the use of face masks in different communities, more so in other countries. Is this something that can also targeted, incorporated in this type of studies?
Yeah, it's a great post, Mia. Thank you so much for that. And I mean, we can only sort of scratch the surface, I think, with this study. And even now with these comments, I'm sort of sort of thinking about the potential sort of possibilities for something more focused on face masks. I mean, my sort of thought in terms of developing and extending things has been very much geared towards thinking about looking at a range of different COVID-19 protective behaviors, amongst which you might expect more variability than we found in our study, but going narrower and becoming more contextualized and thinking about issues like stigma, I think are really, really important. I mean, I think, and here's where we can see that, where the role and contribution of quantitative research methods can only provide, address certain kinds of questions. And I mean, of course, we can think about stigma using quantitative research methods, but I suspect, that some sort of qualitative study would be much better geared to think around those issues of stigma and different kinds of stigma that we could expect within different UK communities and beyond, and how that ties in with the likelihood or not of wearing face coverings. It sounds like a very interesting study.
Livingstone, you have your hands up. If you put your mic on, yeah.
Yes, thank you, Yolanda, and thank you, Dominic, for the interesting discussion here from your study. Yes, thank you. I was just thinking, yes, it's interesting because you used the theory of planned behavior, and I was looking at it and thought, there were factors that probably made you study more complex, in the sense that usually you may have the theory of planned behavior operating in a more natural sense, where people are focusing more on health probably as the key cue for action and intention for changing behavior. But what we see through the pandemic is we had episodes where face coverings were mandatory, and then times where face covering was free and by choice rather than mandatory. So different episodes. I don't know whether you found any differences in your results regarding to these different episodes of face coverings being mandatory and times where face coverings were just recommended rather than being mandatory or being statutory. Yes, that's number one. And then number two, I think we got a situation whereby for some people the vaccination wasn't quite clear, and some people fearing the vaccination with all the things that were being spoken around vaccination and the time when that it had not taken enough time to be developed and tested. So for some people then face coverings became their protective instrument. Yeah, so I was just wondering how these kind of factors came into your studies and how you dealt with them. Thank you.
Yeah, no, thank you very much for the question, Livingston. And then again, these are yet more sort of complicated factors that we could think about with any study like this. And that's this is a really, I think that with your first question about time, I mean, we collected data for this study between really sort of September 2020 and February 2021. I'm pretty sure it was that 6-month window there. Clearly we were sort of in the middle of we were at the start of the second wave then in the UK, I guess, of the pandemic. And we were just emerging from either the second or the third wave of the pandemic, depending how you count it, at the end of February 2021. But that issue of time and the dates and when COVID-19 protective behaviours, with face covering being a really cool one, changes in whether or not that was mandatory and how people's feelings about that would be something that would be very interesting to model. I mean, looking at data of response provided as a separate variable, and that's something that could be very interesting to look at with this data set. It's not something I've looked at the moment. It's something I'm tempted with your comment here to go back and have a look at. And there was the other question, or there's the other point you were raising there, Livingston, about sort of about the movement between these different COVID-19 behaviours. I mean, there could be some quite complicated ways of modelling this, really, but thinking about sort of compensation on wearing face coverings where there was ambivalence or outright discomfort with the idea of becoming vaccinated. So thinking about the interaction and the maybe reciprocal relationships between these different COVID-19 protective measures, I think that would be, that was certainly beyond the scope of this study, but that would be a fascinating piece of work to look at.
Thank you.
Thank you.
Thank you, Livingston. So I'm trying to talk with the chat. With a lot of congratulations on your talk, and really interested. I cannot see any other question here.
Having a look through.
You can have it through. Yeah. Okay. Thank you. So you say, Dom, well, looking at that, you say you within this study, didn't sort of you look at the different timings. Yes, I got that right. I mean, between whether it was mandatory and whether it was voluntary to use face masks. You in your different times that you were running questionnaires, you couldn't identify any differences.
I mean, it's not something. So I haven't controlled for sort of date of response as a. Okay. I haven't controlled for that in the logistic regressions that we saw for the main sample and for the subsample. But I mean, exactly as I said in response to Livingston's comment, I would be quite interested to run that. I mean, there's been so many different things involved in sort of having these published in the first place, that's sort of particular discrete sort of considerations around variables to include in the regression model of sort of been sort of put to one side, I suppose. But I would be very interested to go back and look at that as a factor. I suppose you might there were peaks and troughs, and there were particular legal mandates at particular times. So there was that lockdown in November, and then there was a more formal lockdown in December and January. So you might expect some fluctuation, but I suppose people were scared and that bit likely to be erring on the side of caution. So with that in mind, I suppose you might expect people were fairly consistently wearing face coverings. I mean, living in sort of Islington, I see people, sort of pretty consistently wearing masks throughout the last 2 years, I suppose, or the last 18 months maybe, but fairly consistently during that period. So I wonder if there would be an effect, but I think it's something I'd like to look at now, and as a potential variable to control for in the analyses at the very least.
That could be, alongside probably perceived severity or vulnerability to catch COVID. I mean, I suppose that's another one influencing people's responses. I mean, how they perceive their self-risk and the consequences of that.
Yeah, and these were the main. I mean, these are the main social cognitive models that have come up in the literature so far in relation to COVID-19 behaviours. I mean, I suppose theory of planned behaviour variables are the way in which I sort of is my starting point for thinking about kind of proximal determinants and or sort of behavioural determinants of behaviour. But most of the social cognitive models that have been used in the context of COVID-19 protective behaviours that I'm aware of are more protection motivation theory type models of looking at perceived severity and that kind of thing. So there's scope to do all sorts here.
Yeah, I agree. But I agree with you that the theory of planned behaviour is quite, I think, suitable to look at individual responses. I think it's a very interesting model, especially to look at this distinction on intention as well. So yeah. But as you say, there are different variables too, as well, that could be explored alongside that individual model and responses. Okay, so if we don't have perhaps any other questions or comments, I think people are starting to leave. We have a long day today as well, with lots of meetings. But so okay, so people are just leaving. Thank you, Chris, Jan. Okay, so
thank you
perhaps
everyone.
we can go. Yeah. Thank you very much.
And thank you for
Also
hosting, Yolanda. Thank you for letting me talk about my research.
No problem. Pleasure to listen to your talk. Okay, so the recording is going to be uploaded to the YouTube webpage, then hosted within the Centre for Primary Health and Social Care. For those of you who would like to come back to more detail and to Dom's presentation. Thank you very much, Dom. So, by the way, I'm going to stop the recording there. Thank you very much, Dom, and talk to you soon.